duodenal bulb. This should not be confused with a tumor or a stenosis. Mucosa of the pylorus is flat and sometimes protruding into the duodenum, while surrounding mucosa of the duodenum is covered by villi. The papilla is not visualized in all capsule endoscopy studies, as the passage through the duodenum may be quite quick. The minor papilla in general is missed. Capsule endoscopy provides a good underwater visualization of the entire small bowel, showing Kirk-Ring's folds and villi. However, missing control of movement and lack of cleansing options may sometimes jeopardize visualization. Installation of fluid at flexible enteroscopy provides a good view of the villi. Correctly focusing normal villi may spare biopsy. However, search of early-stage celiac sprue, Whipple's disease or eosinophilia, for instance, may require a biopsy of normal mucosa. In the proximal jejunum, folds are tight together. Jejunum comprises the proximal 2/5 of the entire small bowel. Sometimes a capsule camera shows the mucosa while looking backwards and moving down the small bowel. This double balloon enteroscopy shows the typical orange color of the small bowel mucosa. However, color of the normal small bowel depends on the type of instrument as well as on filling of the lumen with water or air. Here, the endoscope is advanced down the small bowel by rotating a spiral overtube. There is no clear border between the jejunum and ileum. Now the ileum is reached via oral approach. Kirk-Ring's folds become sparser, and the vessels are getting more prominent. These changes are also seen at capsule endoscopy. Here, the endoscopic view through an air bubble gives a different impression of the mucosa behind. Veins may appear quite prominent. This is normal if they remain flat, straight, and if the finding is distributed homogeneous in the distal small bowel. White lines on the edges of the folds are normal, as they represent a view between the villi bend to both sides. In the terminal ileum, villi are getting more sparse and longer. Lymph follicles are seen. Especially in children, they can show a marked hyperplasia. Passage through the ileocecal valve may take several minutes to hours, until a view from the cecum is obtained. After retrograde intubation of the terminal ileum at colonoscopy, a better localization of findings is obtained by the possibility of air insufflation and to control the endoscope position. Installation of water improves visualization of villi. Further application of color selection modes as narrowband imaging additionally enhances surface contrast. Endoscopes with confocal laser microscopy allow visualization of villi on a cellular level. With mini-probes, this technique can be applied during enteroscopy in all parts of the small bowel after intravenous application of fluorescein. Note the visible flow of erythrocytes in the capillaries. Variants of normal are a frequent challenge. Bulges, mobile impressions from outside with normal mucosa, change their size and shape in contrast to submucosal masses. The overlying mucosa and vessels are temporarily being stretched. Small venectasias are not considered as relevant bleeding sources. Focal lymphangiectasias, with an aggregation of swollen and whitish villi, have no clinical relevance. White or yellow lymphatic cysts are striking but harmless as well. Depending on wall tension and viewing angle, these lesions appear elevated or flat. Small blood vessels are typically crossing unaffected over these cysts.
The Naviade BGE device comprises an add-on disposable two-balloon element and an air supply unit. The Naviade air supply unit is placed with any standard endoscopy console, with its indication panel indicating the balloon status located near the monitor. The BGE disposable is easily mounted on the tip of a standard endoscope, with its front balloon sheltered within its rear balloon. The front balloon is advanced or retracted manually. It propagates within a dedicated external channel, leaving the endoscope tool channel free. The balloons are operated by the dual foot pedal of the ASU. Advancement is achieved by sequential balloon operation. A BGE procedure begins with the endoscope being pushed into the small intestine as far as possible. Deeper advancement is then achieved by sequential BGE steps. A BGE step begins with inflating the rear balloon to anchor the endoscope tip to the intestine. Then the deflated front balloon is advanced ahead of the endoscope and inflated to anchor it to the intestine. The rear balloon is then deflated and the anchored front balloon is pulled while the endoscope is pushed through. As the endoscope reaches the front balloon, the rear balloon is inflated and the front balloon deflated. Subsequent steps are performed as needed, advancing the standard endoscope deep into the small intestine. Following a BGE step, the endoscope may be pulled and shortened with the rear balloon inflated.